Buenas tardes a todos,
Good
bienvenidos
afternoon, everyone. Welcome to this webinar in observance of the World Hypertension Day. We will now give you the instructions so that you can access the interpretation services. You're all connected to this event. Thank you very much for being with us on time. And there's a globe at the bottom of the screen. If you click on that globe, you can select the language of your choice so that you can hear the interpretation. So that is where you will find the interpretation. I don't know whether you are seeing this on the screen, but these are the instructions. And I hope that most of you have had experience with Zoom. Welcome, everyone. Please use the interpretation globe at the bottom of the screen so that you can select the language of your choice. And now we'd like to welcome Dr. Pedro Ordóñez, advisor on non-communicable diseases and mental health from the Pan American Health Organization. Welcome. He's muted. Thank you, Gloria, and thank you, colleagues. Thank you, everyone, for connecting to this webinar commemorating the World Hypertension Day. Today, we have a very interesting program, and I'd like to welcome each and every one of you. We are celebrating the World Hypertension Day, but we're doing this in advance. And what we want to do is draw the attention to the very severe problem that hypertension poses for the world and for the region in particular. And with the hypertension campaign all over, we know the number, we detect the blood pressure. Once you detect the blood pressure, make sure that it is well taken, well measured, and let us improve the control of high blood pressure. Today, we have a wonderful program, and let me tell you about it today. This webinar is making a joint effort between Hearts in the Americas Initiative, the Pan American Health Organization initiative for this region, Hearts in the Americas, and the Lancet Regional Health Americas, the magazine you know that is involved in the scientific situation. They've been dealing with this for a year, and it's a pleasure for me to introduce Dr. Thaisa Avila. Thaisa is the editor-in-chief of the Lancet Regional Health, and I invite Thaisa to open the camera. Thaisa will be moderating with me this session, this webinar. Thaisa, good afternoon. It's a pleasure to greet you. Hi, how are you doing? How are things in Rio? How are things in Rio? Could you tell us about it?
Hello, good afternoon. My Spanish is not good enough, so I'm gonna stick to English and Portuguese for today. It's really nice to be here. Thank you, Pedro, for inviting the Lancet Regional Health to join the webinar. And this is really nice for us to celebrate the two papers that we published together. And I hope to have a really nice afternoon with all of you.
Muchísimas gracias, Thaisa. ¿Qué tal? Bueno, mira,
Thank you very much, Thaisa. And now let me explain to all participants how we've organized the program, and then we'll delve into the program. But we will have two main blocks. One first block dedicated or a segment called the health policy. And during that first segment entitled Health Policy, the main speaker will be Professor Norm Campbell. And then we will have four panelists. Once Professor Campbell concludes his presentation, then we bring in the panelists. There will be a round of Q&A. And I invite you all to start writing your questions on the chat. After that, we will have a second segment, and it will be devoted to policy and action. And therein, the keynote speaker will be Professor Jeffrey Brettler. Later on, we'll introduce him with all the credits, and there will be a panel answering some of the questions. And then last but not least, we will have one final round where we will have a colleague of yours, Thais, the editor of the Pan American Public Health publication, and our keynote speaker for today, Paul Welton. So without further ado, I want us all to make sure that we have the right channel. We now have close to 400 people connected to this webinar. That's not bad. The YouTube channel is also open for people to connect. And so let me give the floor to my co-moderator, Taisa. It's a wonderful adventure. We've never done this with two moderators, but we'll see how this goes. So let me call on you so that you can introduce our first panelist. So go ahead.
Thank you, Pedro. So I'm really honored to be the one introducing Dr. Norm, which all of you may know. It's a big celebrity. Dr. Norm is a professor emeritus of the University of Calgary, and he's also past president and current advisor for the World Hypertension League. His work advocating for low sodium reduction and improvement of hypertension control has brought him many awards, including the Order of Canada for his contributions as a research and public health advocate. So I'm not going to go any further, but Dr. Norm will talk to us about, he'll talk us through his most recent work, the health policy entitled the 2021 World Health Organization Guideline on Pharmacological Treatment of Hypertension, Policy Implications for the Region of Americas. Thank you for joining us, Norm, and it's all yours.
Thanks so much. It's a real honor to be here. It's a pleasure for me to present to you and celebrate. It's a pleasure for me to present to you in celebration of World Hypertension Day. The actual day is May 17th, and we're a little bit early. I was asked to talk about policies that would support the implementation of the World Health Organization Guideline on the treatment of hypertension. A much more detailed presentation is in the brand new The Lancet Regional Health Americas publication that's indicated on this slide. I must say I'm very impressed with the new WHO guideline. It's very practical, and if implemented would result in a very large improvement in the management of hypertension. The new World Health Organization Guideline on the treatment of hypertension presents a tremendous opportunity to reduce death and disability from ischemic heart disease and stroke, which are the leading causes of death and disability in this region. Increased blood pressure causes about 50% of ischemic heart disease and stroke, and is the single leading reversible risk for death and disability, both in this region and globally. Arguably, the strongest evidence in all of clinical medicine is that the prevention and treatment of hypertension reduces death and disability at a population level. We're very fortunate to be in the Americas. The Hearts in the Americas program is the world's most successful platform to enhance population control of hypertension and can be revised to adapt to the new WHO guideline. A very high priority must be, therefore, to revise the Hearts in the Americas program to develop and implement new policy approaches that prevent and control hypertension, including this new guideline. I will like to comment that hypertension control contrasts very sharply with the last 2 years of very chaotic, very expensive, low-quality evidence that was used in the COVID pandemic. During the same period of time as the pandemic, most would be surprised that high systolic blood pressure was attributed to over 20 million deaths, while the COVID pandemic is estimated to kill a very substantive number, but approximately a third to a quarter that of high systolic blood pressure. If even a fraction of the world's effort to control the pandemic was placed on hypertension, we'd have very markedly reduced death and disability to a much greater extent, in my opinion. Unfortunately, there's a very common perception that once a treatment guideline has been developed, the work is done. Nothing really could be further from the truth. The work is only really started. There are many barriers to implementing recommendations, including lack of training, education, resources, including budget, access and affordability to the various different medications and technologies that are required, and even regulatory barriers to implementing the recommendations. These barriers require very careful policy consideration, development, and implementation for a guideline like the WHO guideline to be implemented. We are very fortunate, as always, under the great leadership of Paho and Pedro Ordonez, that we have put together an expert team with great experience and representation from across the Americas to consider what policies were needed to successfully implement the WHO treatment guidelines. And this is really a call to action for countries to start to consider and implement these various different policy recommendations. In this slide is the Paho team. I feel very honored that I was asked to lead this team. We have really world leaders, Sonia Angel, who really started the ball rolling with the standardized treatment in the Americas program. Dr. Jaff from Kaiser, who led the development of the Kaiser program, which resulted in 90% blood pressure control, and many other people who have played very strong leaderships in prevention and control of disease in their countries and globally, including Dr. Paul Welton, who was one of the key figures in the new WHO guidelines and prevention and control efforts for hypertension globally. I was asked to give a couple of examples of recommendations in the WHO guideline and what their policy implications may be. One of the examples is that there will be a lower threshold and target for pharmacotherapy in individuals at high cardiovascular risk. The policy implications are very broad for this particular recommendation. It requires revision to education and training programs for healthcare professionals, adjustments to the screening programs for hypertension to account for these new thresholds and targets, revision to the diagnostic and treatment algorithms, an increased primary care capacity and corresponding budget, revision to drug purchase forecasting, an increased budget for the increased need for pharmacotherapy, and a change to the monitoring and evaluation system. So a fairly simple a recommendation, and an important recommendation, requires substantive changes to policies. Another very important but fairly simple recommendation is not to delay pharmacotherapy for laboratory testing or cardiovascular risk assessment. Often people have had treatment delayed because of lack of access to laboratory testing or simply because a cardiovascular risk assessment has not been done. This can result in the complications of cardiovascular disease and lack of treatment. The policy implications of this recommendation are much more simple. They include education and training, as well as revision to the therapeutic algorithm. Another on the surface fairly simple recommendation is to initiate treatment using combination therapy, 2 or more drugs, preferably in a single pill combination. This sounds very simple, and it can just be as simple as changing a treatment algorithm. However, many formularies do not include single pill combinations. In many settings, although it's possible to have an inexpensive single pill combination, they can be very expensive. This requires careful consideration, negotiations, and potentially with collaboration of other groups, including the Paho Strategic Fund, to be able to get a highly affordable single pill combination treatment. Another very important WHO recommendation is that pharmacotherapy of hypertension can be provided by non-physician professionals such as pharmacists and nurses if they have proper training, if the regulatory authority allows them to do so, if there are specific treatment protocols that can be followed and physician oversight. The policy implications for this important recommendation include countries and healthcare facilities reviewing the regulations for services provided by non-physicians to ensure that they include this ability, and that programs of education for nurses and pharmacists, if they're going to be utilized, are revised to provide standardized high-quality education to allow them to do this in a safe manner. There are also several different issues. In some cases, physicians can be quite resistant to this. In other settings, the nurses or pharmacists may require more remuneration as well as responsibilities. So a fairly simple, very important recommendation can become complex and take time. I have not provided all of the different recommendations in the WHO guideline. I was told that this would be tedious and that we have a panel discussion where some of the other recommendations can be brought forward. We are at the cusp of a very important opportunity to prioritize hypertension prevention and control using highly proven, cost-effective interventions aided by the brand new WHO guidelines. If we implement these, we'll have a major reduction in death and disability in our countries. We'll be able to strengthen our primary care and community capacity, resources, and collaborations. I'd like to take again the time to wish you all a very happy World Hypertension Day, May 17th, 2022. I really look forward to the panel discussions. Thank you so much.
Muchísimas gracias, profesor Norm Campbell.
Thank you very
por
much,
su
Professor
excelente
Norm
presentación.
Campbell, for that excellent presentation.
Entonces,
and then now, I will invite our panelists, those who've been invited to participate to this session. And let me introduce them comme il faut, but I'd like to introduce Dr. Patricio Lopez Jaramillo, Dr. Jose Ruales, Dr. Kenneth Connell, and Dr. Beatriz Champagne. To please open up your camera. And also Professor Norm Campbell. This is a panel made up by 4 plus our keynote speaker for this first segment that is devoted to health policy. And I'm hearing on the chat to please share the link, Taisa, of today's publication. Taisa, while we wait for the panelists to show up, why don't you tell them a little bit about how this was published in today's The Lancet Regional Health. So Taisa, please go ahead.
Yes, I just dropped the link in the chat. So the May issue has the 2 papers that we're discussing today, and it also has an editorial about it. And it does have 2 other papers around cardiovascular risk that you also might be interested. And we combined it all in a really nice special edition for this month. And it went online this morning. So if you follow that link, you can download all the papers for free and you can read the editorial as well.
Excelente. Después vamos a virar.
We'll come back to the editorial because the editorial is a piece that I highly recommend that you have it available at hand. It's a very summarized, only 1 page, and it takes you to the main topic that we're covering, and it's written in a very attractive way. So I highly recommend that you read it. So let's move on to the panel. I'd like to invite Professor Patricio Lopez Jaramillo. I can't see him now on my screen, so I don't know whether he's with us. So Patricio, please. Patricio, he was in Madrid. It seems that we have problems with the connection, but we have a solution for everything here. So since it's a good opportunity, let's move on to Dr. Beatriz Champagne, who has to leave a bit earlier. So Taisa, what if you ask the question to Dr. Champagne? So Taisa, please.
Yeah, so for those who don't know, Dr. Champagne, she is the head of Healthy Latin America Coalition and former executive director of the Inter-American Heart Foundation. So she's been working for a long time with the civil society and other issues around it. And I would like to hear from her. What messages would you consider relevant for the civil society from the piece that we just heard about?
Yes, thank you. Voy a hablar en español.
I will be speaking Spanish, so thank you very much, Taisa. And I'd like to thank Pedro and Norm Campbell, who always want to hear the voice of civil society. I am representing, as a coalition, I'm representing several entities from our civil society in the region. They all base their activity on science and scientific evidence. However, I do want to mention that science and evidence not always win when we're trying to bring about such an important program as is the hypertension control program in our region. The Hearts for the Americas program is a very successful program. And even with that, we've faced difficulties in being able to control hypertension in a majority of people with hypertension. We find that sometimes one patient who talks to politicians or policymakers, and they talk about their difficulty in having access to medicines, that they don't have the resources to do so, that they cannot have access to the closest primary health care service. Maybe if they also had a stroke, as perhaps they would call it, and that they cannot move the arm, they lost their job, the family is impoverished. Someone who talks about their experience and their testimony, sometimes that this is stronger than all the evidence, all the norms, and all the rest that we have as a people based on science. And I believe that it is essential to understand this, that we have two things that are happening if we look at it from the point of view of civil society. On the one hand, we are excellent in dealing with technical, scientific, clinical issues. There's a lot to be done. But in the health sector, we have a lot that has been done and a lot of successes. But on the political side of it, there's a huge gap. I see that what we have is difficulties in being able to reach the most vulnerable populations. That frequently has to do with inadequate or insufficient budgets. So looking at the work, the document that was just published, there's a table 4, that has certain ways of responding to those barriers, and those barriers are hurdles. And I see that there are two that are of a political nature. And I think that civil society can contribute in a very broad way, because the others, I see them as more within the health sector. And these are things that can be done from the health sector. But let me just mention these two, and I apologize, but I will use this because it's a very fine print and I can't see very well. So one is in inequality, inequity in access to treatment and medication that is of high quality and accessible. And the other one is health systems, that they be designed to be able to deal with a chronic situation such as hypertension. So these two are something that I see as essential to which civil society can contribute. And as to the rest, civil society can use it and can contribute to all the others as well. But civil society, what we have in Latin America by way of civil society, that has been able to get taxes on sugar drinks, smoke-free environments in almost all countries, and now they have alcohol control issues in other countries. I believe that this civil society plays a very important role, which is to have an influence, a bearing on these issues. And I believe that it is there where, from the point of view of civil society, we can contribute. Thank you. Very good. I want you to know, and this talking about WHO guideline, TAISA, that WHO guideline also had the point of view of civil society, and Dr. Champagne represented the civil society in the committee, the WHO committee. And this is something that people don't know, Beatriz. WHO invited patients, civil society, to heed their perspectives about recommendations. So that means that the recommendations offered by WHO is not a cold document, but it also has the opinion of civil society and patients. I will now call on someone else. We've lost Patricio, but we have a solution for everything, as I was saying previously. So now I will skip one and we'll take care of this later on. But Taisa, what if we go back to another one of your guests, Dr. Jose Ruales? And you can moderate the question, please, Taisa.
Yes, I have a pleasure to welcome Dr. Ruales, who is the Vice Minister of the Ministry of Health in Ecuador. And from his perspective, we would love to hear what he considers relevant for a Ministry of Health in this context.
Obrigado. Muchas gracias.
Thank you very much. And very cordial greetings to Pedro, and my gratitude and recognition to the work done by Paho through you in order to promote the Hearts Initiative and the work it does throughout the Americas and the co-panelists. It's a great pleasure to be able to share a panel with Beatriz and also with Patricio Lopez Jaramillo. I see in the upcoming panel that we have Martin Villatoro, because we've worked with him in the past from El Salvador, but the Ministry of Health in the country, Ecuador, just like many other countries, it has a high share of chronic conditions. Currently, they represent 43% of the total mortality, and 25%, 1/4 of it is linked to cardiovascular disease, CVD. And in keeping with our latest survey, in people over 18, close to 20% has the prevalence of high blood pressure, and 60% does not know that they have the condition. They're not knowledgeable about their situation, about hypertension. And that is why the initiative and the guide are quite relevant. The guide presented by WHO. And what we want is to have an implementation at a national level, and therefore we've reproduced the work that was just mentioned by Pedro. We've set up a national technical working group with national experts, with officials and policymakers all across the board, Social Security, the Ministry of Health, the private sector, and universities. And based on that analysis, we've concluded that there's a need to adopt the WHO guide officially by the country. We've transformed and we've introduced some minor adjustments, some tweaks as a guide for clinical practice for the treatment of hypertension in adults that will be mandatory throughout the health subsistence at the country level. And this is very important because it already finally provides us with a normative structure from a clinical point of view, as well as for the development and proposal of public policies that already become a national agreement, a national consensus. And based on that, we are developing as priorities the work for the strengthening of capacities of professionals and the intersectoral connection within the health sector, but also with local organizations, with civil society, and especially with the municipalities and with the entities dealing with the promotion of health, because they are not directly having an impact on everybody but the Ministry of Health. And the other one is that from a political point of view, we're reorienting the approach to the disease to a comprehensive integrated health promotion prevention, concentrated on the individual, on the risks, but also on protective factors.
And hence, I think the initiative and the guidelines have been very important for developing our own national strategy to control hypertension. Thank you very much, Dr. Ruales, Vice Minister of health of Ecuador. And I have to say, Ecuador is one of the champions in the area, one of the countries that are best developed in terms of hearts. They have over 1,000 health centers implementing this initiative. And Dr. Ruales said, we are going to adopt the heart initiative, and they have included within their health plan. And they said, this is what we're going to do. Another thing he said is, we have the WHO guideline, let's adopt it too. Now we have our next panelist is Kenneth Connell, who is a professor in the University of the West Indies in Barbados. He was part of the group who wrote the WHO guidelines. Sometimes the universities are outside this. They don't teach this. Well, they may say we have the guideline, but we don't teach it. But you, who are the deputy dean of the University of the West Indies, what do you think of this that we are doing, Dr. Connell?
Thanks so much, Pedro, and happy Hypertension Day in advance to all 531 viewers and my co-panelists here. So I want to start by referencing the Campbell Lancet paper. And to me, the most important graphic is seen on page 3 of that paper, which really shows these pillars that support the vision of hearts. Hearts will be the institutionalized model of care for cardiovascular risk management with special emphasis on the control of hypertension and secondary prevention in primary healthcare in the Americas by 2025. Now, we are in 2022. We are also in the middle of a pandemic. The only way that hearts will have the longevity and the sustainability necessary is if the next generation of healthcare professionals are trained. And that's as obvious as it really comes. Now, one of the pillars identified by hearts is training and education. And I know that Paho and WHO have done an excellent job in providing online webinars and courses for healthcare workers, and even sometimes for patients to go onto the website and get information. I now think we need to move things to a much higher level. I think that the instructional design within our universities, medical students, nursing programs, pharmacy programs now need to be incorporated into their pedagogical design for courses so that there is no conflict between what is being taught in hearts versus what is being taught in some of the related courses. And I will use my university as an example. I happen to be co-examiner on the cardiovascular block, which is from the medical students. There are many things that are related to hearts. For instance, how to do a blood pressure accurately, or how to start patients on medication and screen for cardiovascular risk. It's so easy to use the materials provided in hearts, but it has to be done in a very structured way. And obviously, as a multi-country university, we also have to make sure that what we're teaching at the Cave Hill campus in Barbados is the same as what is being taught in Trinidad, in Jamaica, and in Nassau as well. And it's so much easier to do so if you have a standardized set of documents. So I think that universities have a critical role. We are often criticized as being quite abstract and in our ivory towers, but this is not the case with hearts. Hearts started as evidence-based protocols. It developed into a very practical set of protocols and algorithms to be used by countries. What is now necessary, and this is critical, I think, moving forward, universities now need to incorporate this into their teaching structure, into their assessment, in residency programs. And I want to just close by stating that many students who are taking the formal MBBS or MD programs are not always exposed to an MPH or Masters in Public Health. Hearts has a unique advantage in setting the scene for the care of the hypertension patient in front of the practitioner into a wider society, because it references things like healthy lifestyles, access to medications, all those things that residents in a busy hospital setting don't usually think about. It forces them to see the bigger picture of the social determinants of health. And this, I think, is critical. So my challenge to universities and also to the WHO and Paho, how do we now get hearts to be more integrally involved into the educational design for the next generation of practitioners? Thank you.
Muchas gracias,
Really
doctor Connell,
good.
por su...
Thank you very much, Dr. Connor, for your reflections here. I hope many university professors are listening to what you just said. Um, yeah, someone graduates, they and then only then will they start learning the practical guidelines. No, we could already include that in the curriculum, and society will be more benefit if we have a more practical approach for nurses, doctors, and other medical professions. Now we have Dr. Patricio Lopez Jaramillo, president um, of the University of Santander in Colombia. He is a well-known researcher and well known by the heart people, and he is an academic. So I would like to ask Professor Jaramillo, Lopez Jaramillo, what is the relevance of the article in the Lancet? Why is it relevant for the academic world, for the world of researchers? So over to you. Thank you, Pedro, for your introduction. Yes, as a president of the University of Santander, I've been there 4 months, but we are going to do our best so that for our all professional health um, schools, nurses, pharmacists, medical doctors, we will incorporate all these practical approaches of heart. Norman, I want to apologize to say that these are guidelines for uh, pharmacological treatment. Guidelines from WHO uh, it should also lead us to talk about lifestyle changes and other changes necessary. We have here a pharmacological approach. But once we have clarified this, I have to say that the article published by you and referring to the guidelines has an advantage for us because we have a global approach here. First of all, it needs to be a team effort with community participation. And when we are talking about this, we are talking about accurate medicine. We are talking about the most modern things because we need to be preventive, predictive, participative, and individualized. And we so the scheme as presented by Hart is essential. This outline is excellent. We've had prior experience through studies such as COP3, where we saw that combined therapy, uh, which can be which can then go to full dose, allowed us in a year to control 70% of our hypertensive patients in those municipalities where we use the HEART program. So we see here one of the clear evidence that with this kind of treatment managed by a team in collaboration with the community using the hearts outline. And only in 1 year in Malaysia and Colombia, hypertension was being able to be controlled, similar to what Norman has up in Canada, where your medical system is more advanced. And I would like to say that we do need to understand that control here happens at primary healthcare level when we are able to demedicalize and deinstitutionalize management of hypertension using standardized methods as proposed by Hartz. We will be able to improve all of this. My friend Ruales was saying, how can we improve the number of 20% of controlled hypertensive patients? One of the alternatives is what Hearts proposes. So thank you, Pedro. Thank you, Norman, and to the whole team, to the whole Hearts team, so that we, through simple, easy to implement measures, we are able to control this huge risk factor for cardiovascular disease. Thank you very much. We have excellent panelists here, and they're so connected to the reality, so at the core of the problem. We should have had 2 rounds of questions, indeed. But here in this first round, we have really achieved a great deal. Now I give it over to Dr. Norm Campbell to give us a final reflection. And then I'll challenge our panelists that in a half a minute, they give us a final message that you would like to convey. Please, so now reflect for a little bit. What is your final message?
Well, thank you so much, Pedro. I think each of the panelists made incredibly important points. For Patricio, perhaps even more important than the treatment of hypertension is the prevention of the increase in blood pressure. And this is where a lot of the disparity and inequity come in, and really requires a broad public health policy. Increased blood pressure is not a normal phenomena for humans. It's something that we've done in the way we've structured our society. The incredible need for community to engage to be successful in controlling hypertension was emphasized by Dr. Morales and Champagne. And the countries that are going to be successful are the ones that can use a whole of society and community based approaches. To Dr. Connell, I can only completely agree with you. We teach medical students and nursing students how to do the wrong thing and then wonder why they're not doing what we want them to do. And fundamentally, we really need to come back and teach people how to use the right blood pressure device instead of the wrong one, which we're currently do, how to use systematic approaches instead of the chaotic approaches that we sort of teach in schools. And so we teach them the wrong thing, and then they do the wrong thing, and somehow we're surprised. We need to come right back to the building blocks, as you indicated. But this is why building recommendations is the easy part. Implementing them really requires very careful thought, coming back to the policies and the very fundamentals and restructuring how we do things. Great panel.
En medio minuto, final round.
Muchísimas gracias, profesor Norm Campbell. ¿Qué tal entonces? Vamos al...
Thank you, Professor Campbell. Now let us give a final message from the panel. Now, we have 531 participants, but we have opened the YouTube channel. So those who weren't able to join us here, they are watching it through the YouTube channel. So if you are listening to us, please send messages to your colleagues. We ran out of room here on Zoom, and that's great. So now a last round of messages for our panelists. Beatriz Champan, thank you, Pedro. My message is that we need to urge people to know their right to health and that they demand action by their governments. And this is going to contribute not only to improving the overall situation, to have increased access to medications, but also it will push for accountability, because people can demand to know what is going on in their countries and why they need more powerful action in our Latin American countries. Thank you, Dr. Champagne. Kenneth Connell,
So
Your last
hypertension.
message for the audience.
Sure. Thank you, Pedro. So hypertension is a major public health emergency. It therefore is unethical for universities not to focus on the management of hypertension and to rapidly incorporate it into their instructional design for the training of doctors, nurses, pharmacists, and all healthcare professionals. The next generation of healthcare professionals need to be equipped with the necessary tools, knowledge, and skills to treat the public health emergency before they leave the formal training of an institution. This cannot be done post-graduation. We have a moral responsibility to ensure that our graduates are adequately prepared to fight this war.
Muy bien, doctor Connell. Y Patricio, ¿qué nos dice entonces?
Okay, Dr. Connell, thank you very much. Patricio, what is the last message you want to give to those university presidents and rectors, deans, etc.? Well, first, improve the awareness of the importance of hypertension. It's not possible that only half of the people who have hypertension know they have it. Two, improve availability and access to medications that effectively control blood pressure. Three, in terms of public health policies, we need to improve the message in terms of changes in lifestyle. But so the hypertensive person who has no pain, no itch, they wonder, why do I need to take medication for the whole rest of my life? We need to improve education, awareness of patients, of how important it is to adequately manage hypertension. All right, thank you very much. Excellent. So Ruales, Dr. Ruales, what would you tell the ministers, vice ministers, those who are listening to us? I also think that we need to work on three basic topics. First, public policy. Public policy needs to be by majority. It has to generate standards, structure, so that what Patricio says can be done, to have the resources available to buy medications, to be able to assign appropriate health teams, distribute staff appropriately, health personnel appropriately. Also, it needs to be participative. This is not work that only the Ministry of Health can do. As Beatriz said, we need to work with civil society, but also with academia, with local organizations, with municipalities to generate healthy spaces, to reduce problems of obesity, eating, reducing alcohol and tobacco consumption, eating healthy, etc. And we need to emphasize awareness and knowledge among students in health personnel. We have trained 35,800 health workers using the HEART tools, and we have 403 health centers, and we have in a 10-year plan, we will reach 1,600 health centers, and we have incorporated the basic drugs into the schedule. We need to have clear standards and policies, training, education, awareness. These are key to implement in our countries. All right, well, what can I say? Taisa, would you like to give us some final words, and then we will have a short break. So Taisa, over to you.
Thank you, Pedro. It was really good panel. And yes, we did cover our second round of questions with the first round. So do you want me to move to the second one? Or, yeah?
Vamos a la pausa activa, que nos tienen preparada una pausa activa para que
no, we have an active break. No, we will have now an active praise, and a big round of applause for the first panel. But now let us go to our active break.
Thank you.
Bueno, colegas, espero que estemos todos bien activos. Ya ustedes ven, Bolivia, uno de nuestros...
Okay, I hope we're all active. Bolivia is one of the latest countries to join HEARTS, and they have finished their training and they're ready to start, and we're ready to start. Congratulations to Bolivia. The rest of the countries, please put your messages in the chat so that you can communicate amongst yourself. We are a community of countries. We are learning from each other, and there are many things that we can share. And this is why we're using all the ways we can. We're going to go to our second segment, and I have Dr. Jeffrey Brettler from Southern California, Kaiser Permanente Medical Group. He was the leader in this group of innovation hearts group. And in one of the articles, the editor of Lancet, Rena Health, has said, oh, please read Jeffrey Brettler's article on hypertension. I leave you now with Dr. Brettler. Over to you, Dr. Brettler.
Greetings. I am Jeff Brettler, an internist and hypertension specialist from the Kaiser Permanente program in Southern California. And it's a real pleasure to participate in World Hypertension Day today with all of you. And today I'd like to talk with you about key drivers, scorecards, and the heart's clinical pathway as a real practical way to improve hypertension control and primary care practice. And this is my agenda for the next 10 or 11 minutes or so. I want to give you a little bit of background, but then really delve into what are key drivers and give some specific examples. We'll finish up by talking about the Hearts in the Americas Innovation Group and a couple of important scorecards, the Heart's Maturity and Performance Indices. So let's start with just a little bit of background. As all of you know, systolic blood pressure continues to be the most important, the most modifiable risk factor for early morbidity and mortality globally, and we're not doing well. So the hypertension cascades are shown on the right here, and blood pressure control is only being achieved in 35% of women and 23% of men in the Americas. And in the Americas, cardiovascular disease accounts for almost 2 million deaths annually. So this data strongly argues that we have to do something different. We have to take a different approach, a more intensive approach to really improving blood pressure control in all regions. And we have an outstanding document for how to begin this important work, and that's the WHO updated hypertension guideline published last year. And it really gives us specific guidance on a number of important areas, including when to start medication treatment, what medications to use, the importance of fixed dose combination pills, cardiovascular disease risk assessment, what should our target blood pressure be. For the first time, some direction on what the frequency of assessment should be, and also importantly, it stresses treatment by non-physician professionals. So this work has to be included in any hypertension work moving forward. So let's shift our focus a little bit and begin to explore the concept of key drivers. Now, quality measures can be characterized by either structure, process, or outcome measures. And typically, we spend our time and energy thinking about outcome measures. So in the world of hypertension, that's blood pressure control and coverage. But equally important is the notion of process measures. So these are the specific care delivery elements that lead to improvement in your outcome measure. And those specific delivery elements are what we call key drivers. And what's important is that they are directly under the control of the provider or clinic. Now let's look at a particular example, in this case from my system, Kaiser Permanente in Southern California, how application of this notion of key drivers and their associated process measures can be helpful. So here is an example of our hypertension control across 13 different large medical centers. You see some natural variation in performance, but then the question arises, how does Medical Center A perform so well, and what are they doing differently than Medical Center B? So I think the answer really lies in how these systems perform with these key drivers or process measures. So here is Medical Center A, the high-performing medical center. And when you look at 4 specific important key drivers, repeating the blood pressure when the initial one is elevated, treatment intensification rate, follow-up after an elevated blood pressure, and bringing the patient back in if they have not been seen within 12 months. As you can see on the slide, Medical Center A performs extremely well in all 4 process measures. Now let's compare that same scenario to Medical Center B, a medical center that does not perform as well in overall blood pressure control. And as you can see here across these same 4 process measures, now performance is not as high. And what's important here is we can actually direct the medical center where they need to put their efforts. So the 2 process measures on the bottom of the slide, follow up after an elevated blood pressure, and bringing the patient back in if they haven't been seen within 12 months are 2 key areas that this medical center needs to focus on. Now let's look at a couple of specific drivers that improve blood pressure control just to really illustrate this concept. And what I hope to show you is that these drivers are well supported by evidence. There's plenty of opportunity to improve, and they're also well supported by current guidelines. Let's start with the driver accurate blood pressure measurement, and in this case, the specific recommendation of repeating the blood pressure when the initial blood pressure is elevated. And what you can see here is that a single office blood pressure measurement is often not reliable. About a third of initially elevated blood pressures will normalize with recheck. And there's plenty of opportunity to improve. So in this study in US healthcare systems, only 23% of the time when that initial blood pressure is elevated is it repeated. And you can see there's broad support with international guidelines to do so. Let's look at another key driver, the use of a standardized treatment protocol. In this case, an established protocol with use of a fixed dose combination pill. There's great evidence that this is an effective strategy. We know that most patients require more than 1 medication to control blood pressure. And fixed dose combination pills improve adherence and control, and importantly, decrease the length of time to achieve control. We also see that there's lots of opportunity to improve. In one national survey in the United States, fixed dose combination pills were only used 19% of the time, and you can see that there's broad international guideline support for the use of fixed dose combination pills. The last example we'll show today is the driver of team-based care and the specific recommendation of medication titration by a non-physician. There's good evidence that medication titration by a non-physician may be the most effective strategy to improve blood pressure control. We also know there's a global shortage of physicians to treat hypertension, so we must employ a team-based care approach. The opportunity has not been quantified exactly, but we know it's quite large. And we see that there's broad support for this recommendation from both the WHO and the ACC. Here's some of the evidence supporting the importance of team-based care. This is a nice meta-analysis of implementation strategies to improve blood pressure control. And what you can see here is that team-based care with titration by a non-physician was the most effective strategy, even better than team-based care with titration by a physician. And here's another important piece of evidence supporting the need for a team-based care approach. In this case, we're looking specifically at physician capacity in countries with different income levels. And as you can see in almost all settings, but especially lower income settings, there's a dramatic shortage of physicians needed to treat hypertension. Now, to synthesize all of this important evidence and information and to produce recommendations that were both effective and feasible, we formed the Hearts in the Americas Innovation Group, a wonderful multidisciplinary group with participants from 12 countries, as shown on this slide. The group met every 2 weeks for a period of approximately 1 year and really focused on 2 Hearts modules, team-based care and systems for monitoring, with an emphasis on identifying the key drivers that really improve blood pressure control. And to do this, we studied a number of high-performing systems with best practices. This work culminated in a paper being published in the Lancet Regional Health Americas just a few weeks ago, and we're happy to report that this has been translated now into Spanish and Portuguese as well. So hopefully all of you have the opportunity to review. Here's a summary of the identification of those key drivers by the innovation group. You can see the domains on the left, the key drivers highlighted in blue, and the specific recommendations of those key drivers on the right. But the key drivers encompass blood pressure measurement accuracy, cardiovascular disease risk assessment, standardized treatment protocol, treatment intensification, continuity of care and follow-up, team-based care and task shifting, medication refill frequency, and to put it all together, a system for performance evaluation with feedback. Those key drivers and their associated recommendations are then all put into a process measure scorecard, as shown on the slide here. And for each recommendation, there is a specific goal. The scores for each of those 17 specific recommendations are then rolled up into what we call a process maturity index. So we get a single number, which is very helpful because it allows us to trend improvement over time. It also allows us to compare performance between health clinics and health systems. Now, as we mentioned at the beginning of the presentation, we look at both outcome and process measures. So here is our outcome measure scorecard, specifically looking at coverage and control of the population. And this scorecard is called the Heart's Performance Index. Scores on the Heart's Performance Index also get rolled up into one aggregate number, which again allow us to track and compare systems over time. And lastly, and very importantly, all of this very critical information is put together on one page conveniently in the hypertension clinical pathway. So you see the medication protocol in the center, but equally importantly, all of these other key delivery system elements, these key drivers, are also included on this one pager. So frontline physicians and nurses can really see all of the necessary steps to improve blood pressure control in their patients. In conclusion, we want to emphasize that to improve blood pressure control, we must identify the key drivers of that control. We then need to translate those key drivers into process measures and finally use those process measures in a performance feedback system with our frontline clinicians. Key drivers are evidence-based and guidelines supported, and really the identification of these key drivers and process measures is not just an academic exercise, but these key drivers are practical and essential tools for primary health clinics and systems to improve their blood pressure control rates. I'd like to finish by pointing out that we have a wonderful series of modules now in both English and Spanish, which really detail and explain the drivers thoroughly on Paho's virtual campus, and we encourage everybody to check out these courses. We think you'll find them very useful, and I want to thank you for your attention today.
Muchísimas gracias, Doctor.
Thank you very much, Dr. Brettler. Jeff, as we warmly call you. And this is the right time to have our panelists show up on screen. But what these panelists will do, Dr. Frida Plavnik, Dr. Matias Villatoro, Dr. Caroline Malcolm, Dr. Andrew Moran, please open your cameras. And Thais, what if I start with you? And let me ask you a question. Why Lancet, the publisher said, this is an article that must appear on the first page. Why this article appears on the first page, the key drivers? Why do you show this on the first page?
The paper and in the web page today, and this is our way of putting as much attention as we can to what you know better than we do. Is it has the potential of being one of those that guide ignite the change in clinical practice, and this is one of our missions. So the Regional Health Americas aims to be a platform where you can we can just increase the voice of what you do and what is with the final goal of changing clinical practice, which is our common goal, our side and your side. So this is our way of trying to make as much fuss as possible with this one. And I don't know if you scroll down to the bottom of the page, but you can see that the health policy is the first one in the list of the most read papers from the website. So I think we're doing the right thing. We're getting the attention to where it needs to go.
Muchísimas gracias, Tyson. Entonces te voy a dar la
Thank you
palabra.
very much, Taisa. So I'll give you the floor so that you can introduce the first panelist for the second segment. Taisa, please.
Yeah, so I'm happy to welcome Dr. Frida to be our next panelist to talk. And Dr. Frida is a physician researcher in Brazil in the Heart Institute in São Paulo. And she has a very high level expertise in hypertension control. She also, she was a former president of the Hypertension Society, and she is one of the co-authors of the Brazilian Guidelines for Hypertension. So Frida, our question to you is, as Brettler was mentioning, the paper is not supposed to be an academic exercise, but to actually be implemented. And so what do you think is the actual relevance of this to change clinical practice? And do you think the experts and researchers are ready to accept and embrace the proposed changes?
Você consegue me ouvir? Can you hear me? Yes. So I don't know if you wanna.
Yes, we can hear you.
Maybe in Portuguese, maybe. Okay.
It's up to you.
Sim.
Okay. Bom, primeiro eu quero agradecer a oportunidade.
First of all, I would like to thank you for this opportunity to join this webinar. And I would like to tell you that this paper is incredibly relevant indeed. It is truly a change in concept. What we are saying is that hypertension and most patients with hypertension may be treated in healthcare centers by a non-physician and not necessarily overload specialists in order for them to obtain care. So among all drivers presented, we know that some of them will be more easily implemented. For instance, training for hypertension measurement for all professionals. That is already something that the Brazilian Hypertension Society includes in its guidelines. There's a class that people may access and take for free and train on how to properly measure blood pressure. We know that the use of validated equipment seems to be a challenge due to cost even, but on the website, we have shown also other tools so people can access a validated monitor. Other drivers, for instance, will be a challenge once we implement hearts, which is something that should be happening very soon in Brazil. For instance, the concept that stratifying cardiovascular risk, that is so relevant, and it could define each patient's goal, not only BP measurement alone. So in this paper, we have some incredibly critical data, and I believe that we can already start once we start implementing hearts so we can have better results. One of the key aspects that for now at least will be insufficient is the suggestion that titration be done by a non-physician. That is not something that is authorized for nurses. It is a physician-centered task. So that will demand a lot of effort in order to change that policy among associations and councils, since this is a continental country and we do not have physicians always available for titration. Another very important topic contained in this paper, and I even have a question for everyone about that, has to do with scorecards, the development of scorecards. We do not have, or we're not aware of metrics that have been used in developing these scorecards. So the possibility of us using this methodology from the offset to assess our outcomes will be very important. And the question I would like to ask is the following. We know that often physicians do not fill out forms, whether they are hard copies or electronic forms. So I imagine that perhaps the level of completeness of forms may have been considered. For instance, could that be taken into account, whether a form was fully filled out or not? That needs to be taken into account so we can optimize service delivered and outcomes in general. In general terms, I consider this a vital paper. It should be broadly disseminated. And in regards to treatment, Thaisa, there is no question that both specialists as well as researchers already have it very clear in their minds that a combination is the first option that should be selected right from the get-go to start up with the use of FDC. However, it is not possible for us to use FDC in the public health system because they're not available yet. It's something that is currently being discussed in the Ministry of Health in Brazil with the technical groups related to the implementation of the HEARTS initiative. So again, we don't have to worry about suggesting that FDC should be recommended to specialists and scholars. That message, however, does need to be conveyed to basic education providers so that HEARTS as an initiative may bring all the results that we hope to obtain in our country. Thank you very much.
Thank you so much. Muito obrigada, Frida.
Bueno, excelente, excelente. Así que estamos listos. ¿Qué tal para
Excellent. So we're ready. So what if we move on to the second panelist, Dr. Matias Villatoro, coordinator of the office, coordinator, non-communicable disease office, Ministry of Health of El Salvador, one of the countries that just joined HEARTS, but they're doing this at quite some speed for the implementation of HEARTS. So Dr. Villatoro, how important is this article for you? Does it help you in your work in the Ministry of Health? How are you assessing this work, Dr. Villatoro? Good morning, greetings, cordial greetings from El Salvador, and thank you for the opportunity to participate in this webinar, and happy day of World Hypertension. El Salvador has had significant progress since 2010 to 2019 in attaining to reduce the mortality caused by communicable diseases, maternal, perinatal, and nutritional. But by contrast, premature death by non-communicable diseases that concentrate 71% of premature death in El Salvador did suffer an increase, and this for us is extremely important. Therefore, our country, it is necessary to concentrate our attention on cardiovascular diseases, diabetes, and renal diseases, because the prevalence of hypertension in our countries is 77%, and only 40% of the patients are controlled. Therefore, we cannot go on doing the same. We have to implement public policies and cost-effective interventions that are based on evidence. And essentially in order to comply with the commitments of our population, but also with Agenda 2030 on health. Therefore, the key drivers presented for us are so important because they are based on operational actions on how to do things. Because most of the recommendations that are evidence-based tell us what to do, but not how to do it, and in order to move ahead quicker. Therefore, with these key drivers aligned with a clinical path for pharmacological and non-pharmacological treatment, considering cardiovascular risk as a main axis in this management, will be extremely important for us. This will also facilitate the inclusion of new technologies as automatic devices in the list of our equipments, combined medicines, a fixed dose, because they tell us the evidence, blood pressure monitors, because they ask us for drugs and inputs and supplies in order to include these new technologies. Also, for us, it's very important for human resources, particularly because specialists, physicians are not sufficient in our country. However, with the standardized protocols, simple protocols for understanding, this will enable general practitioners and nursing staff to follow up our patients with high blood pressure. These key drivers will also be used in order to measure the quality in the provision of services and to implement the culture of assessment of the quality of the services that we're providing, because we introduce a new indicator, which is patients, controlled patients, and we're not used to seeing them like this. So this will be a challenge for us because obviously we need to implement the registries by name of patients for their follow-up and their control. In conclusion, the key drivers will be used in order to have adequate diagnosis, timely management and diagnosis, pharmacological and non-pharmacological treatment for blood hypertension in El Salvador. Thank you very much. Thank you very much, Doctor. Very encouraging to hear an official from a Ministry of Health, as you, Dr. Villatoro, saying this is what we have to do. And in fact, this is what El Salvador is doing. So very good. Thank you very much. And let me give the floor to Taisa. Taisa, please go ahead. You are muted, Taisa.
Now I'm on
Okay.
mute. I will invite Dr. Terlene Malcolm to join us in this next question. Dr. Terlene is a Paho advisor and project leader for non-communicable disease prevention and control in Trinidad and Tobago. And so from your perspective, what do you think, how do you think the HEARTS is being received in the Caribbean countries? And what are the immediate barriers that you think will need to be overcome to fully implement and expand to other countries that are still not joined?
Good afternoon, everyone, and thanks, Taisa, for that question. I believe the HEART is well received in the Caribbean. Yes, there are still countries to come on board, but it is very clear from the speed of the expansion that there is buy-in. I don't need to speak about the prevalence of NCD in general, and by extension, hypertension and diabetes, especially in the Caribbean, as that is well known. But because of this, countries have been searching for a solution. And many are aware of the chronic care model and have been talking about using the chronic care model, but they were at a loss as to how to operationalize this model. And then HEART came along, and that is a solution. So the practical and easy step-by-step approach using the different technical packages have been made this process so relatable in countries. And most importantly, countries can see improvement quickly, even if they're starting with just one component like the standardized treatment algorithm. So we are seeing countries, for example, the Dutch St. Martin, whose primary care is privately based, is embarking on this journey. So it is clear that there is acceptance of the HEARTS initiative. However, as we know, with system changes, it requires time, it requires buy-in, it requires the involvement of many stakeholders. So there will always be challenges. But I will just mention three of the main challenges or barriers that have been encountered, and some was mentioned earlier by other speaker. I'll start with the drug formulary. So a key element of the HEARTS initiative is that standardized treatment protocol. This would require ensuring that the drug formulary within the country are modified to include those agreed medication that is on that protocol. So countries usually start with a protocol outlining what medication they currently have in country, but then they want to transition to the preferred, those medications that have been proven with evidence to be more effective and will increase compliance with patients. But that would require ensuring those changes. And we have seen that delay in countries to make those changes. And those changes are important if we're able to ensure consistent supply of these essential medications. We also need those changes at the country level to guide the Ministry of Health purchasing intention. So I see that as one of the barriers, one of the challenges, but of course, this takes time. There are strategies that are being implemented to deal with that particular challenge. The other main barrier, which was mentioned earlier by one of the speakers, is the fact that there are local policies and legislation that hinders task shifting. So as it was presented, that medication titration is one of those success factors that can really make a difference in the control of hypertension. But in many countries in the Caribbean, the local legislation only allow for physician to do medication titration. So again, that is another area that would require some system changes, some policy legislative changes to facilitate and fully be able to implement the task shifting at the level that hearts required. And the third area is in terms of the information system for health. We know in the Caribbean and probably in many other countries, there is a lack of a national information system for health. And again, the M&E, the monitoring and evaluation in general, is usually weak. And we know for hearts, the M&E is an important component. So getting countries to understand that they just need to start with where they are at. If that means a paper and pen, then it is really to just get started, identifying those, selecting from the package, those core indicators that are necessary. But the important thing is to ensure that as we are implementing, we have established the M&E component. So I say those would be some of those key barriers or challenges. But I'll end by saying that there are also some key success factors. Getting political buy-in very early is critical. And the evidence, that's the thing about hearts, it has the evidence, it's evidence-based. And ministers of health and those in decision-making position, they want the evidence. They recognize the prevalence of NCD, they recognize the premature mortality that is taking place in their country, and they do want to do something about it. So it is to show how hearts is able to really deal with those issues. Once we have that political buy-in, we are then able to establish that strong governance structure. And that governance structure is at all levels, at the national level, at the regional level, and at the local health facility level. And finally, the collaboration, ensuring public, private, civil society collaboration in the process from the inception is so critical. So in closing, I am recommending that all countries start looking at hearts, start looking at these scorecards, and start focusing on how you can improve, enhance quality improvement and strengthen hearts implementation. And for the countries that have not yet joined the Hearts in the Americas, I'm really urging you to get started because the benefits are enormous, and it will really make the difference that we're looking for in impacting system changes, strengthening the health system at the primary care level to respond to NCDs. So thank you, Thais, and back to you.
Thank you so much. That was really good, Darlene. Pedro, are you next?
Sí, pues adelante entonces nuestro último panelista.
Our last panelist. The fact is that when you have panelists with such a level like Taraline Malcolm, with that sense and knowing really what is happening on the ground, it's a pleasure to hear you and to hear from you what is happening, as we heard from Matias Villatoro, and as we heard from Frida Plavnik with that proposal of leaving it in the hands of the technical camera in Brazil. And now it's a pleasure for me to introduce one of the great epidemiologists and specialists in hypertension, cardiovascular conditions, Dr. Andrew Moran. He's the director of the Global Hypertension Control of the Resolve to Save Lives. And Andrew, obviously, you're a mentor, you're an advisor, a donor, and you do a lot of things at the same time. But now I wanted to ask you, Andrew, in this endeavor that you do promoting hearts all over the world or hypertension programs, what do you think about the concept of drivers, and what do you think this could be practical? Do you think, first of all, that this could be practical for the control of hypertension in the world? So go ahead, Andrew Moran.
Thank you, Pedro. Thank you, Thaisa. And it's a pleasure to join, and happy World Hypertension Day, everyone. So I'm Andrew Moran, and I am the Director of Global Hypertension Control at Resolve to Save Lives. It's a global health nonprofit organization, and we work in 30 countries, including many in the Paho region, to support hypertension control programs using the WHO Hearts Technical Package as our touchstone for the standard approach. And yes, to answer the question, I think that this scorecard developed by the Paho Innovation Group is incredibly important and practical. I think that we often, when we do look at the epidemiology, when we look at the trends globally, and we look at the poor rate of hypertension control in most countries, including the high-income countries, it's very natural to start to blame and to look at the clinicians and the health systems and say, why aren't you doing better? You improve things immediately. It's urgent, call to action. But if we don't tell these clinicians and these health systems and these governments how to improve hypertension control, what happens is cheating. We give people a goal and tell them to get to that goal, and we don't tell them how, then what will happen, people will start entering the blood pressures and the control rates that pleases the government and pleases the global health community, but it doesn't improve health for patients, doesn't prevent heart attacks or strokes. So what I like about this scorecard is that it gives you very specific actions to take to improve the program. And these are very time-tested actions that have been proven in many health systems around the world with a lot of evidence, and they're simple and they can be approached one at a time or in a set together. So we at Resolve to Save Lives are very excited about this scorecard. It simplifies things instead of giving an overwhelming number of things, it simplifies your score, tells you where you're starting, and shows you when you're improving. So we're excited at Resolve to use this approach in other countries, in other regions of the world, because we think it's really an important innovation. So we are very excited about this, and congratulations to the innovation team on this publication. And I think it's a great thing to celebrate. It's something practical and quality improvement approach to maybe for the next World Hypertension Day, we'll have more to celebrate because of that. Over.
Muchísimas gracias, Dr. Andrew Moran, por sus palabras tan estimulantes.
Thank you, Dr. Andrew Moran, for your very stimulating remarks. Now I'll give the floor to Jeffrey Brenner, or Brettler, who, Jeff, what reflections do you have for our panelists for their comments? Over.
Thank you very much to both Paho and Lancet Regional Health Americas for the opportunity to participate. This is a great program, and it's an honor to be part of it. And a big thanks to the 4 panelists who really have made my job easy, because I think they made all of the points that I was interested in making. But as we know very well, hypertension is the most modifiable condition to prevent early heart disease and mortality. And the opportunity really is that we know what to do. It's not like the evidence is not there for how to improve. We think the key driver concept really expands and fills in our toolkit for how to improve blood pressure control, because as was stated by our panelists, it really allows health systems and clinics to focus in on the areas that they're not doing well. And a very important point that's related to this is in our efforts to eliminate health disparities and really create health equity for all, this is a very important strategy in how to do that most efficiently. We look at populations that may not be doing as well. We can now really focus in on why that's the case and really prioritize our efforts to correct it. We think these tools are practical for primary health systems, but primary health systems have to have and create or foster a culture of quality improvement. This does not work without a strong, robust quality improvement system. And as some of the panelists stated, there will be some challenges to this. There are a number of drivers, a number of recommendations, and we have to have data really monitor progress and to see how we're doing. So a big component of all of this is really creating the quality improvement culture in all of our primary health systems. But we consider these to be feasible. The innovation group had representation from multiple settings, multiple countries, and these were all deemed to be feasible to implement. And one may ask, do we need to implement all of them? Well, the answer really is yes, we think we do. Many of these are interrelated. So as an example, to facilitate team-based care approach, you need a specified protocol, especially one with fixed dose combination. So all of these, or many of these indicators work together, and they all should be implemented because they are guideline-based and evidence-supported. And then the last point I would say is really the time for these changes is now. The WHO hypertension guideline really should serve as a catalyst for change. It's a perfect opportune time to implement these tools, and we hope that these tools really offer a practical way of improving blood pressure control in all primary health systems. Thank you very much.
Thank you, Jeffrey.
Oye, qué bueno saben que estos webinars nunca tenemos tiempo para terminar.
These webinars, we never have time to really include everything, but here we have so many great panelists. I would like to thank all our panelists for this awesome effort in your presentations. And we are talking about we had innovation, then we have the paper already published, we have the course, the virtual course, and at the same time, we also have the webinar. So we have the whole comprehensive cycle for people to know exactly what we're doing. And after that, we will have the translation, so we don't have any language barrier. And the Pan American Public Health Review Journal, and we have Damian Vasquez, and the journal is on its celebrating its 100th anniversary. And now we're going to introduce Damian Vasquez because he will tell us what is happening with a special supplement for the Pan American Journal of Public Health. Damian, over to you. Thank you, Pedro. Good afternoon. It's a pleasure to be with all of you. Thank you for this opportunity. I will briefly like to share 3 things with you regarding hypertension. I have an anecdote, an invitation, and a hope. And these 3 things are anchored in the present, the past, and the future, but they belong to 3 different environments. First, clinical medicine, public health, and second, and third, public policies. In my next slide, you will see a young physician sitting at his desk in his office. Next, please. Next slide. Okay, here we go. Thank you. This young physician, it's not me. That was me back then when I had more hair and less gray hairs. I was sent to a small place in Patagonia in the very south of my country, and I wanted to go deeper with my patients. my specialty was dermatology, so I wanted to go below skin deep. So I wanted to take blood pressure as a screening tool. That's this method that I used to use. And I'm not showing a validated blood pressure cuff, but this was just historical. I used to take my patient's blood pressure. I thought this was effective, quick, and I was able to interact with the patient, talk a little bit with them, just kind of establish a rapport with the patient. Back then, I was not very aware of public health as I do now. And then in the next slide, talking about public health, and as the editor of the Pan American Journal of Public Health, and please visit our journal on our website. You have the website there. This website has a section devoted, as Pedro was saying, to hearts in the Americas. In that webpage, we will have between 15 to 20 original research papers. We estimate that they will be published in the second half of the year. Right now, they're being evaluated, and the editorial process is taking its course. But here we have translations into Portuguese and Spanish of the articles that have been discussed here today, articles that were published in the Lancet Regional Health, thanks to me, to my colleague from the Lancet here. And there's also an article translated into Spanish from human hypertension. So I leave you with this address, www.paho.org/journal. And you have several of them in translations too, so that you can read them in your own language. Finally, I want to leave you with a hope, and it's a hope for the future. As health professionals and collectively as human beings, as humankind, we have defeated smallpox, and we have taken big strides in controlling HIV, tobacco use, and others. And I think that blood pressure control and cardiovascular disease control should be next. So we need to integrate all of those who are participating in this webinar, and those who work daily, researchers, doctors, nurses, general health professionals, authors, academics, and all of those who are related to this topic. My hope is that this silent killer, hypertension, and the associated cardiovascular disease, we will be able to sooner rather than later leave behind, so that we can focus on something else. Thank you very much. Thank you, Damian. In addition to having this human note to this webinar devoted to the hypertension, the World Day of Hypertension. And now that we have the Lancet Regional Head, we have Paho as an organization working side by side with the countries to improve people's health. So before we go to the keynote, which will be with Professor Wheaton, we will take a 2-minute break, and then we will have our last presentation, our keynote speaker, Dr. Paul K. Wheaton.
Trinidad and Tobago has a rich history due to its multi-ethnic community. Our cultural expressions in both food and entertainment make us proud. But our modern way of life, unfortunately, leaves the population vulnerable to chronic conditions such as hypertension. Care for persons afflicted with non-communicable diseases can be a daunting task, as healthcare systems lack the resources for NCD management and have many competing priorities. But with the Hearts Initiative, we are reorganizing how care is provided at the primary care level.
The HEARTS initiative provides a holistic approach to chronic non-communicable disease management, incorporating both public health and clinical primary care in one program. At a population level, Paho works with the Ministry of Health and technical experts, such as primary care experts, cardiologists, and nephrologists, to tailor-make a treatment algorithm that works best for each individual population. This takes into account access to medication while minimizing side effects and ensuring ease of access, as well as reducing the number of physical pills needed.
Trinidad became a part of this Global Hearts Initiative in July 2019. And it's a partnership between the Government of Trinidad and Tobago and the Pan American Health Organization and the World Health Organization. The Hearts Initiative is a new way of delivering health services, reforming the way in which we currently deliver health services in the primary healthcare setting.
The Hearts in the America initiative is a global drive for strengthening the health system to provide better care for NCDs at the community and individual level. The government of Trinidad and Tobago has been pleased to work with the Pan American Health Organization and World Health Organization since 2019 in reorganizing the provision of care and scaling up of the implementation of this initiative.
This program is part of the government's attempt to get the population to be healthier, to take charge of their health. And let's reverse the burden from being a treatment-based model to a preventative-based model. Take control of your health. But also, we want to start to treat our children and train our children not to make the mistakes that their parents and grandparents made. So that is why we have a whole program about childhood obesity and childhood health. It's a game changer to change the culture of the way we treat with NCDs in Trinidad and Tobago.
For one, it's making it easier to follow our clients. You get better satisfaction and you get results in a faster time. Previously, what happened, independent physicians or different physicians will see clients and they will treat clients in accordance with their knowledge and what they have seen worked for them over the years. With the standardization of the treatment, what you find is that we follow an algorithm, we follow a set protocol that can be followed by the clients, their relatives, as well as the physicians themselves.
The HEARTS initiative is a team-based approach at its core. The patient will come into the health center. The first line of contact is the clerk, who will send the notes to the nursing assistant, who is also the screening nurse. The patient, of course, meets the screening nurse as well. Where the blood pressure is taken, a short history is done. The nursing assistant or the screening nurse will take the patient and the notes to the doctor, where the patient is interviewed and further counseling done. Medication may or may not be changed. The patient is then sent to the district health visitor or the nurse associated with the program. There the patient receives a greater amount of counseling done on lifestyle changes that can be made, improvements. The nutritionist in the HEARTS-based team effort will advise the patient on the meal changes that need to be made in order to lower the blood pressures. Simple little changes or maybe big changes. From there, the client will leave the nutritionist and head to the pharmacist, where he or she is given medication as well as advice on how to use the medication. The client then returns to the starting point of the clerk, who reminds the client the appointment time, the appointment date for the next visit, and any further visits that may be required, as well as reminding the client to come in for the next prescription.
So we are working to support the Ministry of Health. And beyond that, what we're working to do is actually to help strengthen health systems in Trinidad and Tobago. The reason for us working with the ministry, which is our line ministry, it's because we support the Ministry of Health in taking care of persons with non-communicable diseases. And we are doing that within the context of strengthening health systems overall, which is a critical part of the work that we do at the country level. So the HEARTS treatment protocol is a standardized protocol that will be implemented with persons with NCDs.
They told me then that my blood pressure was too high and that situation has to be addressed and corrected by a change, by medication and a change in lifestyle and what I do. That's when I decided to join the heart group here. I was advised that I need to start testing my blood, recording it, so that I can see which way it's heading, whether it's improving, whether it's getting worse, etc. Among the things I needed to do was to change my diet, because that was a major contributing factor. What was interesting is that the testing now, I got underway with my testing of my blood pressure, and I started to see the drop that is taking place. Like when I started off, my blood pressure was 155 over 96, and at present it's 123 over 75, and it kept coming down and down. And when I discussed this with medical people, they said that present blood pressure rate is quite good. Just keep it there.
Finales de este excelente webinar y
All right, we're coming to the end of this excellent webinar, and I would like to introduce Professor Paul Welton, who is one of the most important professors in the area of public health. He is the director of the School of Public Health and Tropical Medicine in New Orleans, in Tulane University. He has also had expertise working with the American Heart Association. So I would like to welcome Dr. Welton. Please, over to you, Professor Welton.
Thank you, Pedro. It's a wonderful pleasure and privilege to be with you today. And I want to first send every good wish from my colleagues in the World Hypertension League. We have incredible admiration for the accomplishments of Paho. You really provide the model for the way forward, as I'm going to mention in a moment. And I want to wish everybody a very healthy and a very happy World Hypertension Day. So my title is The Way Forward. I have no conflicts of interest. I don't have to persuade you that high blood pressure is the most important preventable risk factor, both in terms of death and in terms of disability-adjusted life years. It's well demonstrated. I don't have to persuade you that lowering blood pressure is beneficial, and then getting down to quite low levels of blood pressure is even better than getting to moderate reductions in blood pressure. We know that part. I don't have to persuade you that despite knowing the importance of high blood pressure and the fact that we can reduce risk, we do abysmally around the world. It's a shocking disgrace. And, worldwide, the last time my colleagues and I looked at this, less than 8% of those in low and middle income countries were achieving even a rather modest goal for control of blood pressure. That is less than 140 over 90 millimeters of mercury. Most guidelines are recommending getting to lower pressures than this. And if one looks in Latin America, there, of course, are a lot of surveys. This is one from the Pure Group. And I'm just going to focus over here, 6 countries. You'll see there's one thing that's common. They're all doing badly. They're, even at the 140 over 90, the control rates are abysmally low. So, there's got to be a better way. This is not acceptable. And I think the way forward is the one that Paho has demonstrated. It's an evidence-based approach for prevention and control of high blood pressure. It's been tested worldwide. It works in the United States. Dr. Brettler is part of an organization that's in the private healthcare arena, Kaiser Permanente. They've demonstrated that this type of model works exceptionally well. In our public health sector in the United States, the Veterans Administration has also demonstrated that a model like what is being used in Hearts in the America works very well. It's been demonstrated to be effective in many other countries, and I'm going to show you one example in a moment. And the elements are fairly straightforward. It's not rocket science. It's really promoting health through lifestyle change, simple evidence-based protocols, both for lifestyle management and for antihypertensive drug treatment, and not overcomplicating the system. This one is key, really ensuring access to effective and affordable medication. And I think that's in many studies been shown to be very, very important. Providing the care in a setting that is convenient to patients, preferably patient-centered care, and preferably, as we've heard, delivered by a team, and making sure that there is accurate measurement of blood pressure, and then tracking to make sure that we know what's happening. Is that patient really coming for visits? Are they measuring their blood pressure at home if we're asking them to do that? Are they getting prescriptions? Are they filling them? How is their blood pressure doing? So tracking is an essential component. So the actual components are fairly straightforward. As we've heard, the key is implementation of this type of model. And I want to show one recent example. This is a cluster design. It's the clusters of villages. It's a randomized controlled trial. There are two components, and I'm going to show you the first component. It's a blood pressure component done over 18 months. There will be a cardiovascular events component as well, will be published at a later stage. And in this particular trial, there were 163 intervention villages and 163 usual care villages. In the intervention villages, the care was delivered by what are called village doctors in China. It used to be called barefoot doctors. They have very modest amount of training. They might be equivalent to a community healthcare worker in the Caribbean or Latin America. They were trained in how to conduct standardized blood pressure measurement and how to deliver health coaching, both for lifestyle improvement and for medication adherence. They conducted monthly visits to achieve the goal, and the goal in this particular trial was a systolic and diastolic less than 130/80. They used, again, a simple step care protocol for medication treatment, very similar to Hearts, was based on the 2017 ACC/AHA guideline. They were supervised by the township primary care physicians, and they had access to hypertension specialists if needed, but that was needed very, very rarely. They instructed patients on home blood pressure monitoring, and they were incentivized financially. They got about a 25% bump in their salary, and their salary is quite modest. In the intervention villages, the patients received either free or very heavily discounted blood pressure medication. And I think that was I suspect, a very important part in this trial. They were given a blood pressure monitor, and as I mentioned, they were instructed how to use it, and they received health coaching. And they had tremendous beneficial outcome in those intervention villages compared to the control villages, both in terms of achieving less than 130/80. Here's the intervention villages, nearly 60%, about 20% for the control group. Even more dramatic if you used the 140/90, which is obviously more conservative. And if you just look at the difference in systolic blood pressure between the two groups, 14.5 millimeters of mercury, it's dramatic. So here we're using the model, and the key is implementation of the model. So I go back to saying, I think that the way forward is to use an evidence-based strategy, the very model that is being used in Hearts in the America, and that's how we will achieve control of high blood pressure in the general population, whether it's in the United States or it's in Peru or Argentina or Chile. And again, it goes back to simple evidence-based protocols, health promotion, community-based care, preferably team care, reliable access to affordable medication, and tracking to make sure that we are achieving our goal. So with that, I want to stop and thank you, and again, express my personal admiration for the work that Paho is doing with all of you are doing through the Hearts in the America program. It's really impressive, and you provide the model for all of us around the world. Thank you.
Muchísimas gracias al profesor Paul Welton por este cierre del día de hoy. Quiero entonces ahora...
Thank you very much, Dr. Walton. I'd like to invite all panelists to please open up your cameras. All those participants who've been with us today, please open up your camera because we have a moment for celebration, Taysa. Remember we said that we had a surprise for everyone. And this is a huge surprise that I want to share with everyone. But I want all their panelists to be on the screen and open up their cameras. After hearing this impressive thing, Professor Welton, for him to say that we're doing fine, that's nothing to despise. If we were not doing that well, he would also let us know. So I'm very happy to come to this moment because Professor Welton was my professor of cardiovascular epidemiology when I used to go to school in the Johns Hopkins epidemiology department. So he used to be my professor. And I feel so excited to come to this moment, which is also very important. I've learned a lot, not everything that he knows, but I've learned some things from him. And also to take advantage of this moment of rejoicement because just listen, we are taking advantage of Taysa, one of the dearest colleagues, the giants in hypertension in the world, participated with Norm Campbell in this exercise on policy, the one that we published, and he died a couple of months ago, Professor Ed Rosella, a giant in hypertension, and I want Hearts to pay tribute to him today. He was a mega figure in the control of hypertension in the US and in the world for his eternal fight. So the cameras are on and there's a huge surprise that we want to share with you. There's a huge event that we want to celebrate with you. So production, go ahead.
Tenemos que declarar que esto
we
fue...
have to say that this was without Paul's authorization. We're not going to say what he's celebrating, but this is a big birthday. And for the community of countries to celebrate you, this is really exciting. It's very moving for all of us. So with this, we bid you farewell. A big round of applause for all our panelists. Excellent presentations. I hope that this has been really motivating. We had a full room. The room was completely full. We couldn't have room for anyone else. We've recorded the presentation in our YouTube channels, and it will be made available to everyone. Those of you who want the recordings, you have the presentations, the videos, you have everything, and you can use it. Hopefully, we can use this in schools. I hope that we can call on everyone. We, Paul, started talking about this years ago, but then we had COVID. But we have some tasks waiting, discussing this with the deans in medical schools. How do we teach this in our everyday for life in order to strengthen the capacity of our health systems? So quite impressive to have a panel with all of you. Taysa, thank you very much for all the effort of Lancet, for the opportunity, and I give you the floor for the closing of today. Taysa, please.
Thank you, Pedro. Thank you for inviting us. And this is a great panel. I think we did a great job putting together the best people to talk. And I think looking at the chat, I think a lot of people were saying that it was really informative and that they learned a lot. And I learned a lot too, because as you know, it is not my background information. So I learned a lot from the best. And it's an honor for us to be holding this, our first webinar with Paho, first of many. And thank you so much for all the panelists that joined us this afternoon.
Bueno, muchísimas gracias. Que tengan una buena tarde para aguantar 2 horas de transmisión, sí, celebrando el Día Mundial de la Hipertensión. Y que
I
ojalá
hope you have a good afternoon celebrating at the World Hypertension Day, celebrating in the 22 countries where we have hearts, and all those who haven't joined us. Have a good afternoon, and thank you very much. We really appreciate your participation this afternoon. Thank you. And we close with this music.